The following podcast is part of a certified educational activity titled The Ideal Connection in Multiple Myeloma, Establishing Ophthalmology-Oncology Relationships to Overcome Ocular Toxicity. Access the entire activity and complete the post-test at peerview.com/AHH860. Downloadable slides and practice aids are also available.
Good evening, everyone. Thank you for being here on a Friday night, and we really appreciate you spending some time with us. I'm Pranita Tulasi. I'm from Emory University in Atlanta, Georgia, and this is Dr. Kaufman, a professor of hematology and oncology at the Winship Cancer Institute and an expert in multiple myeloma. As you know, we are here to look at the diverse suite of treatment-associated complications, specifically in multiple myeloma. Ophthalmologists are usually not here working with oncology drugs. Usually any ocular complications from any oncology drugs are referred to as on an as-needed basis, and these aren't a huge part of our practice generally. But there have been a lot of novel therapies that really have changed the standard of care and the interaction ophthalmologists and oncologists have these days. Many of them have unique mechanisms that seem to affect the eye specifically, and multiple myeloma is a great example of medications that require a lot of collaboration with our oncology colleagues. Multiple myeloma is not new to the ophthalmology world. These patients certainly are immunocompromised, and we see a lot of infectious complications because of their multiple myeloma. We can also see plasmacytomas in the orbit. The hypercoagulability can lead to vascular events, and the immunoglobulins can also result in deposition in the cornea and lead to new corneal opacities in patients with this diagnosis. But what is multiple myeloma?
All right. Good evening, everybody, and thank you for joining. When we were discussing giving this presentation, I just made Dr. Tulasi make a promise that I didn't have to say anything about the eye, and I could just talk about myeloma. So I'm going to talk about myeloma. Myeloma is a malignancy of plasma cells. We call malignant plasma cells plasma cell dyscrasia. There's excessive amount of plasma cells in the marrow. They make the monoclonal antibody. We call it monoclonal spike, M-spike, paraprotein. They all mean the same thing. Again, the plasma cell's job in life is to make antibodies to help fight and prevent infection. And when that plasma cell becomes a myeloma cell or a malignant plasma cell, it continues to make that antibody, that monoclonal antibody. And a lot of the symptoms we see in myeloma are related both to the tumor burden as well as cytokines within the microenvironment. This is the enemy. This is the plasma cell. You guys look under a microscope for different reasons, but when we look under the microscope, this is what we look for. The plasma cell has the very typical eccentric nuclei with the perinuclear huff or halo. That is where all of the proteins are being manufactured, and then the dense cytoplasm where the proteins are being packaged for distribution. There's a spectrum of plasma cell disorders. MGUS is very common. MGUS probably happens in 3% of every 70-year-old in this country. MGUS is defined if there's a paraprotein less than 3 grams per deciliter, plasma cells less than 10% in the bone marrow. And MGUS, by definition, monoclonal gammopathy of undetermined significance, has no symptoms. There's a precursor malignancy that we call smoldering myeloma. To the pathologist under the microscope, it looks like myeloma. They have more than 10% plasma cells. They have a high paraprotein, but these patients also don't have symptoms. And then myeloma is defined as clonal plasma cells in the marrow or tissue, a monoclonal protein in the setting of symptoms. And when we talk about the symptoms of myeloma, we use the acronym CRAB, the CRAB criteria: hypercalcemia, renal dysfunction, anemia, and lytic bone disease. we've learned in those patients who have smoldering myeloma that there's a subset of smoldering myeloma that don't have any of the CRAB criteria, but they're at such high risk of developing myeloma shortly that we've gone ahead and treated these patients. And these are some biomarkers that we use that where a patient is labeled, doesn't have symptoms, but has such a high risk of progressing to myeloma within the next year that we go ahead and call these patients myeloma and initiate therapy. Treatment of symptomatic myeloma is really tailored to the patient's general health and other comorbidities. The average age of a patient with myeloma is somewhere in the late 60s. Having said that, especially at a tertiary care center, we can see patients much younger, but again, the average age in the late 60s, and we have to deal with a significant amount of comorbidities and a decrease in functional status. And the standard approach of therapy, and we left off one of the pillars, and it keeps the cornea doctors in work, is we give regular steroids, and we need our ophthalmologists to help with our constant use of steroids and treatment of cataracts. But the other three pillars are immunomodulatory agents, thalidomide and lenalidomide. We all probably remember thalidomide as a very infamous drug in the history of medicine, where it was given to women for morning sickness, and their babies were born with birth defects. We learned 40 years later that thalidomide was very effective in treating myeloma, and further modifications of thalidomide have led to lenalidomide and pomalidomide and other similar drugs. And now we know the mechanism of action of why the babies were born with birth defects, and we know the mechanism of action of why these drugs work. Proteasome inhibitors have become a mainstay, bortezomib particularly, and we'll talk a lot about bortezomib later in this talk. And somewhat newer is we have monoclonal antibodies, what we call the naked monoclonal antibodies, daratumumab and isatuximab and elotuzumab, all targeting proteins on the myeloma cell. The standard of care remains in a young, and when I say young, in myeloma, when we say young, we're talking under 75 and under. So that's young in myeloma. Stem cell transplant, as long as these patients are fit and don't have significant comorbidities. Now, this what I'm showing you here is data from our center, and I'm showing for very specific reasons. If you look at the top right, the overall survival, this represents 1,000 consecutive patients that came into our practice with newly diagnosed myeloma, and we asked the question, and we treated them in a uniform manner. And the two important things to see here is that the median overall survival for this entire group is over 10 years. And so this is very different than the myeloma of 20 and 30 years ago. When I see a patient for the first time, I let them know that I expect them to live more than 10 years. But the other thing that you'll note about that Kaplan-Meier curve is that there is no plateau. We haven't cured myeloma yet. So patients are living a long time, but they ultimately relapse. The average progression-free survival is in the range of around 6 years, and the average overall survival is over 10 years. And so we still have a lot of treatments in the relapse setting, and multiple relapse happen, and so we need to continue to develop new therapies. What do we do for patients with relapsed and refractory myeloma? We often we sometimes can go back to what we did previously and recycle what we did previously. We now have second and third and maybe even fourth generation of the class of drugs that we use, the IMiDs, the proteasome inhibitors, the monoclonal antibodies, and we mix and match and get some benefit out of that. We still have chemotherapy, conventional chemotherapy. We can go back to high-dose chemotherapy. We have drugs with unique mechanism of action. Selinexor is called an XPO1 or an exportin inhibitor, a new class of drugs in myeloma. And now we have a new target in myeloma called BCMA. BCMA stands for B-cell maturation antigen. It's a great target for a myeloma drug because BCMA only exists on plasma cells. And currently, from a drug, what's been approved is we have antibody-drug conjugates and CAR T-cell. I'm not going to talk about CAR T-cell today, but we will talk about antibody-drug conjugates. Oops. So I know we're all familiar with monoclonal antibodies, particularly in ophthalmology with bevacizumab, but antibody-drug conjugate takes the technology of a monoclonal antibody and combines it to a chemotherapy. So with the monoclonal antibody targeted in this situation, the BCMA, we deliver the chemotherapy in this setting. The chemotherapy is MMAF, and what happens, and that's what you see with the monoclonal antibody, there's 4 chemotherapy molecules for each antibody. And the antibody binds to the BCMA on the myeloma cell, then goes inside the myeloma cell, is cleaved, and is able to act within the myeloma cell, leading to cell death. In addition, because it's a therapeutic monoclonal antibody, it works through its immune mechanisms through antibody-dependent cytotoxicity and other immune mechanisms. And so over the past 20 years, there's been a lot of new drug development, and in these past 20 years, we've developed now an unexpected relationship with our ophthalmology colleagues. We learned with bortezomib now 10, 15, 20 years ago that there's a fair amount of ocular and eyelid complications. And then over the past 3 or 4 years with the development of the antibody-drug conjugate belantamab mafodotin, we shorten it to belamaf. It's easier to say than belantamab mafodotin. With belamaf, we have seen a significant amount of ocular toxicity, particularly keratopathy. And as soon as I say the word keratopathy, I now hand it over to my ophthalmologist colleague. So,
the bortezomib especially is very familiar to our oculoplastics colleagues as well as the cornea intersegment colleagues we have. It causes fairly severe blepharitis, meibomitis, and chalazions, multiple large chalazions in these patients. The overall incidence is still pretty low, but those who do have this can have very, very significant quality of life issues. I've not heard of a patient who's lost vision permanently from a chalazion, but it isn't comfortable or feasible for a lot of folks to keep functioning with large chalazions on their eyelids. This is the biggest case series on bortezomib reported, unfortunately, or fortunately, because it's not a high incidence. And generally, they respond to conservative therapy. And by conservative, I mean warm compresses, lid scrubs, topical or oral antibiotics, and topical or oral steroids. But certainly stopping the medication helps resolve these symptoms a lot better. And certainly speaks for the underlying mechanism, which is really that bortezomib. And we think it's the boron in the bortezomib, right, that leads to these chalazion. Very, very interesting. It's from my experience and talking to my colleagues, it's very rare that an ophthalmologist has ever gone back to an oncologist and said, stop the bortezomib because of uncontrolled chalazion. But certainly the patients are quite bothered by these, and quality of life matters for these patients sometimes. This is a case report where tobramycin dexamethasone seems to have resolved this patient's blepharitis, and that's usually the response we expect. But with persistent continued therapy with bortezomib, these side effects can be recurrent. The belamaf, on the other hand, works on a completely different part of the eyeball, on the cornea, specifically the epithelium. We all know a healthy cornea needs healthy limbal stem cells, and healthy epithelial regeneration is what keeps it safe, infection-free, and nice and clear. We also know the stem cells live near the limbus and as well as in the basal epithelium, something called transient amplifying cells. And these migrate centripetally towards the center of the cornea as well as vertically up towards the superficial epithelium as they regenerate and replenish the epithelial layer. We think, and this is still very much a topic of research, that the belamaf gets internalized by these transient epithelial cells that then leads to their apoptosis, but they still continue that progression, moving through the cornea, both centripetally as well as vertically up towards the surface. And they cause very, very interesting side effects, something called microcystic epithelial changes. We'll talk more about that, but most of the information we have about this medication came from this DREAM2 trial.
Yeah, so in the development of the belantamab mafodotin, or belamaf, this was the pivotal study that led to the approval, and they asked the question, what's the optimal dose of comparing efficacy and toxicity? So they used two different doses in the study, very similar number of patients, 2.5 milligrams per kilogram every 3 weeks versus 3.4 milligrams. And the dose that moved forward with approval based on, again, a combination of efficacy and toxicity. And again, this was done in a group of myeloma patients that had 4 prior therapies and really had nothing left from an efficacy standpoint. And this is sort of the good news, bad news from an efficacy standpoint. The response rate is 32%. So when I tell my patients, about a third of patients respond. And again, this is in a group of patients where there was really nothing else to offer them. Those patients who respond, the median duration of response is 11 months. And so for a group of patients that really didn't have anything, having a third of them respond, and that median duration of 11 months is what led to the approval. Now, from a toxicity perspective, I view this as a very low toxicity regimen. Or therapy, and easy to give. It's intravenous. It's 1 dose every 3 weeks, and I'll just push off the eye toxicity for a moment. The thrombocytopenia, which is very common with a lot of our drugs, is manageable. The other toxicity of note is that it can be associated with an infusion-related reaction, but it's uncommon, approximately 20% of patients. It's rare that it's severe. And there's really minimal things like fatigue. There's nausea in a quarter of patients, but none of them is severe. And then the major side effect, the one that we really have to think about with this medication, is keratopathy. And so keratopathy happens in about 3/4 of patients. A little more than 50% of the patients will have change in their visual acuity. And it's severe at grade 3 or more in somewhere between a third and half of patients. And what's interesting is that the amount, when we did the study, all patients were screened, which is how we practice, and we saw some level of keratopathy in 72% of patients, whereas 56% of patients reported some sort of symptom, blurry vision or dry eyes, or a change in their visual acuity. And so what that tells us is there is some keratopathy that happens without symptoms. And it was a small number of patients who had such visual acuity, who had significant visual acuity change, and then it was rare. Under 5% of patients actually had to discontinue secondary to a corneal event. And so the other thing that's important about it, and this is a busy slide, but what this slide tells us is that of those patients who developed keratopathy, and the standard when a patient had keratopathy or significant keratopathy was to hold the drug, more than 3 out of 4 of them got better with dose holding, and the median time to improvement was 24 days. And so that's about the length of a cycle. So if we hold 1 cycle, then that patient will be better, and we can go back to treatment. And so I'll let you guys look at see what this looks like.
So the study describes keratopathy. Really, they're describing 2 different things. One is dry eye, we'll get there, but really the unique thing to this drug, never seen really before with any of the other chemotherapeutic agents, is these microcystic epithelial changes. These are purely epithelial, intracellular changes that are not related to high pressure that we're used to. They're not related to underlying corneal edema as we're used to. These are purely epithelial processes. We used to see these with some of the older drugs, but those used to be responsive to steroid. None of these seem to be responsive to steroid. They sort of do their thing where they start peripherally, migrate to the center, and then kind of disappear with dose hold. They're kind of challenging to see until you really get used to seeing these, do require high magnification and do require either retroillumination or indirect illumination to visualize these. But once these patients are seen a few times, they're not hard to miss. Another picture of these, they just look like these tiny little microcysts. They always start in the periphery and then migrate towards the center. This is a patient of mine. I just think it's a much profound picture with fluorescein here because they're hard to capture on camera. This is a patient. The first picture is when she came in for screening. Within the first infusion, she had some peripheral microcysts. Not a great photo there. You may see some right at the edge here. And this is when she came back the second time. Much more profound microcysts with changes entering the central visual axis. And hers was bad enough that she even had some underlying stromal edema from just loss of integrity of her epithelium. The last picture is after a couple of dose holds, and her symptoms completely resolved and her exam returned back to normal. As the same patient, the first picture here, again, is after one infusion. She had a lot of punctate epithelial keratopathy that kept worsening and almost had that limbal stem cell pattern here with a lot of whorled epithelium, and all of those resolved with dose holds. And both of these are considered keratopathy as defined in that DREAM2 study, both those microcystic epithelial-like changes as well as the punctate keratopathy that we are more used to. Now let's go through a case here. Dr. Kaufman?
Okay. Patient is a 73-year-old woman with relapsed refractory myeloma. 4 prior lines of therapy have failed her. She does have what we call standard risk disease, so we don't expect it to be rapidly progressing. We don't expect to see extramedullary disease and things like that. As standard of care, she had proteasome inhibitors or PIs, IMiDs, again, things like thalidomide and lenalidomide, as well as anti-CD38 antibodies like daratumumab or isatuximab. She does have mobility issues. She uses a walker, history of cataract surgery. She previously had a vascular event. And then the question is she a candidate for belamaf? When should the ophthalmologist be consulted? How should she be consulted on ocular toxicity and what to expect? Is the primary event, vascular event, worrisome? So I'll just take a stab at this. This is really the ideal candidate for belamaf. Her performance status is limited, and there's nothing in her history that would prevent us from moving forward. Prior cataract surgery, other eye disease doesn't limit us. And if we're considering belantamab mafodotin for her, then absolutely she should see an ophthalmologist. And I'm interested in what you have to say. What I tell patients is exactly what I said to you, which is, in general, this is a very well tolerated medication. If you're one of the lucky 1 out of 3 patients that responds, I expect to get almost a year out of it. The biggest thing I worry about is keratopathy, and the good news is that if we're going to monitor it really carefully, and if you get keratopathy, we can hold the drug, and the vast majority of people get better, and then we can go back to treatment.
Yeah. As far as contraindications, there really aren't any absolute contraindications, but if a patient has severe ocular surface disease, severe dry eye, pre-existing really anything on the ocular surface. If they have a compromised cornea, history of cornea transplants, LASIK, Fuchs dystrophy, really anything that could make them more susceptible to these side effects, they may not be the ideal patient for belamaf. The other thing is these patients' vision fluctuates dramatically, and if their lifestyle is not compatible with fluctuating vision, then they may not be candidates either. So in terms of addressing these, especially for bortezomib, if I'm correct, you really just refer these patients as needed, right?
Yeah, I think this is something where we wouldn't refer everybody for an initial evaluation. It's not that common, and for the most part, we can follow the simple measures of the warm compresses, antibiotics, and so forth. And it's when those aren't effective is when we make the referral.
Right. And usually conservative therapy or even, above conservative therapy is tried. And if they are recurrent, if they are non-responsive, and really only in those situations is when the question of discontinuing bortezomib from an ophthalmology perspective would come into play. But most patients can be managed with conservative therapy. Belamaf is a whole another beast here.
Right. Yeah. I mean, and as I mentioned, I think before we start treatment, we counsel the patient on the potential toxicity. We make the referral to the ophthalmologist to make sure to make sure there's not established keratopathy for another reason, significant dry eye, as well as to really establish a baseline. While on therapy, we query patients about vision changes. In fact, we saw a patient who had had a clear exam 2 weeks prior to dosing, but came in and told us that they had unilateral vision decrease in visual acuity, and this happened just yesterday in my clinic, and when we held therapy and have him go back to see Dr. Thalassi and team. And I think this is really where, at least in my clinic, we all need to be asking our patients about vision changes. And this is one of those issues that, again, with the likelihood of recovery, this is one of those issues where we really don't want the patient not reporting to us. And sometimes patients don't want to report to us their symptoms because they feel if they report their symptoms, then they won't be able to get the treatment they need. And so it's very important that we have that good communication with patients. This is where the nurses and the APPs are really important.
From an ophthalmology perspective, we do see these patients very closely prior to their first dose for their screening exam to make sure they're good candidates. And it is very important to get a really good visual acuity on these patients because that is the baseline against which we are measuring their performance. Prior to every dose, these patients require an eye exam. And it doesn't have to be exactly just before their dose. It can be 1 week after their previous dose and within 2 weeks prior to their next dose, and so on and so forth. Whether they have keratopathy or not, these patients are placed on a very aggressive ocular surface regimen, so preservative-free artificial tears at least 4 times a day. And if I need to use things like Restasis or Xiidra, if they have underlying dry eye to begin with, mild dry eye where they would still be good candidates for belamaf, we optimize them before they get to the treatments. A good dilated exam, as with any oncology patient, because they always have surprises in the back of the eye. And if they need things like new glasses, if they need cataracts addressed, really anything we can do to kind of get them to a great baseline prior to starting this medication would be ideal. The scale we use to grade these patients is something called keratopathy visual acuity scale, and it's unique to belamaf here. And they have about 4 grades that they can progress through. Normal is their baseline exam. Grade 1 is mild keratopathy, and this includes, like I said, both microcyst-like changes as well as punctate changes, and very minimal change in best corrected visual acuity. And this always gets us. Patients can come in with quite dramatically fluctuating vision, but all we care about is their best corrected visual acuity. And this is something to keep in mind is their refractions do change. They do tend to get hyperopic and myopic shifts as the treatment progresses, but all this grading scale requires is their best corrected visual acuity at the time of their exam in that office. Grade 2 is when they have more moderate changes and more profound decrease in visual acuity. And grade 3 and 4 are what we hope to avoid, to hopefully never get, but much more superficial keratopathy, profound decrease in vision, and or corneal epithelial defects or ulcerations. Looking at it from a visual perspective, grade 1 is those peripheral corneal microcysts. Grade 2, they're starting to kind of get close to the center, but still spare the central 3 to 4 millimeters there. Grade 3 are much more confluent, central microcystic epithelial changes. And grade 4 is when they have a frank abrasion or other ulceration, really anything else beyond that point. And this goes for the microcystic epithelial changes. Punctate epithelial changes, we would grade them as we would any dry eye patient, mild, moderate, severe, kind of following in that grade 1, 2, 3 category there. What the oncology folks do, it really depends on the grading we give them. And, it is important to have, continuity if possible, because a lot of that grading can be, especially the superficial keratopathy can be somewhat subjective, and it is nice to have the same person seeing these patients over time. For grade 1, really we just kind of keep going and use conservative therapy, right? Grade 2 and above is when you start modifying therapy. Grade 2, we hold belimaf until their symptoms regress and restart at the same dose. Grade 3, you hold until the symptoms regress to grade 1 and start at a reduced dose. And once they get to grade 4, there's a serious discussion about discontinuing that particular therapy. What happens in these patients with dose delays or reductions? I'm always worried when I tell these patients that they're grade 2 or grade 3 that somehow I've let them down and now I'm letting their melanoma get worse. But it doesn't seem to be so.
Yeah, and so we were talking earlier. I find it, that balance of the difference between the mild and the moderate, and that it's sort of a somewhat of a subjective call. And from my perspective, with the knowledge that patients after they've delayed dose, that it's the minority of patients in the context of a dose delay progress. It's not 0, but only 13 of the patients progressed. And I've had patients hold for 3, 6, 9, 12 weeks. And so it's very important for me that the determination of keratopathy, the scale, is as objective as possible, and not really worrying about the negative impact on the patient's myeloma, because the vast majority of these patients will remain stable until their keratopathy gets better. And so sometimes I view keratopathy, patients don't require toxicity to have a response, but sometimes those patients who have more keratopathy, they're the ones who have the deeper response. So there's some type of relationship between it's almost a dose, what the body sees, and it's marked by keratopathy, tells us how well the drug's working. And so I can confidently hold drug for 3 weeks, 6 weeks, 9 weeks. We have the one patient together who I'll let you describe, but clinically he develops keratopathy. We hold 1, 2, or 3 cycles. He gets better, and then we retreat.
Right, and we've been at it for 3 years now with this gentleman. Very predictable pattern that certain patients follow. Yeah. the take-home points really from our end is these patients do need to be seen, and they do need to get a good exam with a good best-corrected visual acuity, a slit lamp exam as well as fluorescein staining to identify their keratopathy and to appropriately grade them and manage them. Because from my perspective, my goal is to never let a patient get to grade 3 or grade 4 because we really want to stop that medication much prior to getting that severe. And these patients do have visual acuity changes subjectively. They do get better with a best corrected visual acuity often, but it's impossible to change glasses every 3 weeks. So functionally, they may have visual acuity changes, but all of these patients do recover if we stop the medication or hold the medication. Now, what we don't know is what this drug is going to do long term. We know that these microcysts affect the very superficial cornea, just the epithelium and maybe the anterior stroma, but we also know they seem to be doing some structural damage to the nerve plexus. There seems to be some nerve fragmentation, and this is pretty early on, within the first couple months after belimumab, and the significance of this long term is just not clear. There are case reports of these patients having very profound, almost limbal stem cell-like pattern of fluorescein staining, but this seems to be completely reversible. But repeat stressors to those stem cells, we just don't know. We just don't know what's going to happen. But at the same time, these are folks who failed 4 or more lines of therapy, and oftentimes there aren't great next options. Going back to our patient here.
Yeah, so after, so she actually, this was a patient that participated on a clinical trial, and I had mentioned earlier that that belimumab had a low toxicity profile relative to the typical medications that we give. And so it makes it really an ideal drug within oncology to be a partner with our other agents. And she participated on one of our clinical trials, the combination of belantamab, bortezomib, and dexamethasone, all 3 drugs with known ocular toxicity. And after she started therapy, she had, after 2 doses, she had grade 2 keratopathy. She did develop toxicity from bortezomib after starting therapy also. And with the bortezomib-based toxicity, we had was able to improve with just conservative ocular management. And then with the belantamab, we held for 2 cycles or 6 weeks. It got better. And then we, according to the guidelines, we resumed at the same dose. It's really an interesting question at this point. It is not only, and I think there's questions in the chat, what we're learning about the keratopathy is not only is it dose related, it's frequency related. And if we can, especially in the responding patient, we can spread out the dose. So, and sometimes, including dose reductions, we've spread out the dose with planned treatment every 6 or 9 weeks. And that way, even if they develop keratopathy grade 2, by the time it gets to 6 weeks and they see you, they no longer have the grade 2 keratopathy.
This particular patient, she stayed on oral doxycycline for quite a while, but you're right, I've managed her cataracts from the dexamethasone, I've managed her chalasia from the bortezomib, and she's going strong. I think year 2, maybe year 3 here on the belantamab, and has a very predictable set of infusions, dose holds, infusions, dose holds for this particular patient. Now, if she had had grade 3 or higher, right, we certainly would have held her infusions and started at a reduced dose for her. Yeah. To summarize, really, the bortezomib-related ocular complications, while rare, can be particularly bothersome, and conservative therapy is often enough, But some of these patients may need more aggressive management. And keep in mind, these are older, sicker patients, so it could certainly be a masquerader like sebaceous cell carcinoma. So it is important to just kind of keep a broad perspective when seeing these patients. And particular to belamaf, these are partnerships with these patients that can last a long time. And the prescribers who dose belamaf are required to enroll in something called Risk Evaluation and Mitigation Strategy Program per the FDA. And just a very, very significant part of that is monitoring for all these side effects and appropriately dosing them with ophthalmology management hand in hand here. It is very important for most of these patients to counsel them appropriately, that they will have significant ocular vision fluctuations and that they will need drops frequently, and to reassure them that any ocular toxicity is manageable and does not seem to very significantly adversely affect their systemic prognosis here. My go-to, I start everybody on preservative-free artificial tears 4 times a day. And the little subset in these patients using steroid drops did not seem to provide any benefit. In fact, we had a patient or two with some steroid response. And there's no definite contraindication to contact lenses, but any patient who wears soft contact lenses and has contact lens-related dry eye may want to be counseled against wearing these contact lenses. There are folks who use scleral lenses for some of these patients to manage their severe dry eye. And again, it has been very much an anecdotal thing. There's no trials looking at kind of systematically at some of these therapies. And again, we do this as well as I know your team of nurses as well do this. Let every patient know that driving and operating anything sensitive while using belamaf can cause problems and need to be done carefully. This is a drug that's required a lot of co-management, but this won't be the last drug, unfortunately. I'm sure you have others in the pipeline that require lots of ocular monitoring here. Yeah.
So I have a question for you. Do you need to be a cornea specialist to do this, to be a partner with the oncologist who's treating myeloma patients?
No, you do not. I think especially following that KVA scale, being able to see the microcyst is the most challenging part there, but once a provider is comfortable with visualizing those microcysts, they do not need to be a cornea specialist in particular. Because I'm in academics, we have the luxury of having it be a cornea specialist, but it doesn't have to be one.
Right. And we were talking earlier, there are some oncologists in the community that are not able to give this drug, which is an important part of our treatment for myeloma patients, because they don't have their a partner in an eye professional as a partner. So I say if you are an ophthalmologist and you hang a shingle that says you know how to do this, you'll find an oncologist out there who's looking for you. So.
And these are certainly patients who are very appreciative because they've certainly gone through the ringer over the past many, many years with multiple myeloma. Yeah. Right.
Great.
I know we have a few questions, but anything from the audience here?
Hello. Can you hear me?
Yes,
we can.
Would you say that there's a cornea at risk, such as an average central corneal thickness or an endothelial cell count, that makes some of these patients more likely to have the keratopathy?
As part of the DREAM trial, some of those measures were looked at, and none of them seemed to be associated with the keratopathy changes. This seems to be purely epithelial. This does not seem to be affected by the underlying, stromal or endothelial pathology, except, I do have a patient with Fuchs dystrophy. He's got, mildly decompensated Fuchs dystrophy, and he, every time he gets these microcystic changes, he does have a fairly pronounced loss of vision that changes months to recover. So I would say, to be on the safe side, if there is any underlying corneal pathology that you think could affect, the healing from a, kind of a compromised epithelium, they're probably not candidates for belamaf.
Thank you. All kinds of meibomian gland dysfunction treatments, IPL, lipoflows, all kinds of stuff. Would it be useful to pair with somebody who has that type of additional interest and the ability to do those kinds of things? Is there any evidence that that would help support the continued use of this drug?
Right, so as we said, there's really two things, right? There's those microcystic changes. Those do not seem to respond to anything we throw at them. So, Restasis, Xiidra, serum, you name it, vasoconstrictors really don't seem to respond. They kind of do their thing. The dry eye component, I do think, could be modifiable, right? But that's usually not the most prominent thing that affects their vision, because these patients are they all carry their artificial tears. They kind of know the drill with the dry eye. But I do think that can be modifiable with everything you've mentioned. Those microcystic changes, though, are a little bit more stubborn.
And blepharitis, for instance, IPL seems to work really well against chalasia, and having the ability to do maybe a BlephX or other things is kind of setting a baseline, and then having hypochlorous acid and or Cleardex or other things that might help to manage the blepharitis better.
I think that's, especially in patients who are on bortezomib, I think that's a great idea. There's no clinical trials, but I think it's such a small percent of patients who have these side effects that you're right. Absolutely.
I thought there was another question over here.
I think I may have answered it in my own head. When do you decide to include Restasis, and are you doing it in the hopes that it'll help up the road as the effect of the Restasis comes to bear?
So in patients who have pre-existing dry eye, I do start them on some sort of anti-inflammatory to optimize their surface, so to speak. Again, the data is just not there that any of these seem to modify the incidence of punctate keratopathy significantly in the setting of this drug. But I do not think it's a bad idea to start Restasis by any means. I don't know if it's going to, I cannot answer that it's going to make a huge, meaningful change in the management of, especially that KVA scale, because it's predominantly guided by those microcystic epithelial changes. But I think the patients would certainly be more comfortable.
We've got, please.
So most oncology drugs don't require a risk mitigation strategy, but I do understand that thalidomide and Revlimid can cause birth defects. So the emphasis is to prevent a pregnant woman from inadvertently getting a dose that was scheduled for a myeloma patient. Now, this drug has a REMS, so I'm really surprised to hear that. So what is it you're not telling us about the non-ocular toxicity that they would require a REMS?
The REMS is solely for the ocular toxicity. Solely for the ocular toxicity. Apparently, the FDA thinks the vision's important. And apparently, there's a handful of people around here who would agree. It's that important. I have to be honest, we were surprised when they came out with a REMS, but without a REMS, there is no belantamab mafodotin. I think we were surprised also, but I think it gets back to there's just not this easy and tight relationship between regular oncologists and ophthalmologists. And the fear was, and I think there's a lot of questions online. The fear was we weren't going to see it, and then people were going to become blind, and we were going to act in the hope of helping the patient's myeloma. People were going to become blind, and this is why we have a REMS.
I also had another thought. Other BCMA-targeted therapies like CAR-T BCMA, which is really taking off. Yeah. Is there keratopathy with that as well?
The keratopathies from the chemotherapy, from the MMAF, the antibody drug conjugate. It's the chemo. So it's a great question, because in theory with an ADC, it could be from the targets, the monoclonal antibody. It could be from the linker, but from the chemotherapy. This is specifically this chemotherapy causing the keratopathy, not BCMA.
So it's not the actual antibody.
It's not the
really
antibody.
So is there evidence that the MMAE basically gets cleaved off of the antibody and it's free in the body to affect the liver or the eye or whatever?
There's enough free MMAF in the body to affect the eye. That's correct.
And I think the mechanism of how it affects the eye is still very much sort of nebulous. It seems to affect those stem cells. It seems to cause very much sort of a stem cell pattern of changes. How it gets there, why is it the blood vessels? Is it the tears? We don't know. Right? Yeah.
Great questions. So we have questions from online that I'd like to share. So I think, how quickly can patients be started on belamaf once we recommend it, including coordinating exams? From our perspective, we usually can get this done in a week.
Right, because we have that, relatively tight partnership.
Right.
Yeah.
So but in order to give belamaf, the REMS has to have, the oncologist has to sign up, the ophthalmologist or the eye professional has to sign up, and then the infusion center that it's delivered has to sign up, and the infusion center has to see sign off from me. It has to see sign off from both of us to say it's okay to give. So it usually it takes about a week. I'm gonna maybe let you answer the second question.
The second question is about whether there's a sense that patients with baseline mild to moderate dry eye or blepharitis or any ocular surface disease are more likely to suffer keratopathy than those without. The answer is yes. I do think so. I think if they have some underlying compromised surface, I do think they get that punctate epithelial changes much more frequently. I don't know if I can say definitively for the microcystic epithelial changes. Those do seem to be kind of their own independent beast. I don't think DREAM2 fleshed that out either. The study hasn't fleshed that out either. Yeah.
And there's a question, if not caught early, how bad can this get? And I think the answer is we don't know, because we don't let that happen. And we don't let that happen because now in clinical trials is because we practice per the clinical trial with regular visits, and now with the REMS program because we have regular follow-up. And then, which is another question, there was another question about is how severe can it be? And patients can get corneal ulcers. I don't know if you've ever seen corneal ulcers.
We haven't, but there is one patient in that DREAM2 study who did end up progressing to grade 4 corneal ulceration. And that person healed, at least, per the data, but it can happen, especially there's just a handful of patients who get just profound microcystic changes after one dose. And it is, something about that particular person or that particular cornea, it is unclear. But, knock on wood, haven't had anybody go to grade 4 keratopathy.
And there's a question about eyelid complications with other agents in the bortezomib class. And so there's another boron-based proteasome inhibitor called ixazomib. And ixazomib can be associated with ocular toxicity. It's much less frequent than bortezomib. And there's a third drug called carfilzomib. Carfilzomib is a proteasome inhibitor, but works is a completely different drug with no boron. And there's no ocular toxicity. Let me rephrase that. There's no predicted ocular toxicity with carfilzomib. So this isn't a proteasome inhibitor effect. This is truly a drug effect. You look like you have a question.
So other MMAE type oncology drugs like Kadcyla in breast cancer, do you see any ocular effects?
I would anticipate the answer is yes. But
there's a couple other ADCs that do report, but it's so early. Some of these drugs are relatively new, and all we know is what they report in the study saying, ocular side effects. It's not very clear. There's really not much data about similar microcystic epithelial-like changes happening. Yeah.
Kadcyla has been out 10 years, I should say.
Oh, sorry. I think I was talking about the other ADC, the antibody drug conjugate.
Yeah, Kadcyla is a HER2
not the
MMAE conjugate.
Okay.
Yeah, there might be. So it's clear there's not as much, and I don't think that's obviously poorly understood, and it might have to do with the amount of chemotherapy per antibody where there's 4, and there might just be get a higher dose of the chemotherapy. I'm not as familiar with the breast cancer world.
And I can look it up and get back to you. I'm not sure.
But it's clearly not. They don't have a REM, so it's not
Right.
clearly not as bad. Question in front.
Yeah, there was a question about this fluctuation in vision and myopic and hyperopic shifting. And the question is that a corneal event related to, say, the microcyst, or is this something happening at the lens or some other level of refraction that is obvious?
It's related to the cornea, especially when they get those microcysts. They do seem to have some like kind of flattening and steepening type effect there. They do have topographic changes when you follow them with topographic changes. But at least for the purpose of following these patients with that KVA scale, as long as they best correct too close to their baseline, as for getting the infusion, it's irrelevant. Functionally, for a patient, you're absolutely correct. It can be profound changes on their visual acuity.
So I think there's a lot of questions online that I think we answered during the talk, but there's one question that that is a good question. I just lost it. Does lower doses of belamaf result in less frequent, less severe ocular toxicity? And the answer is yes. We dose reduction, but at the different one in the DREAM 2 study, comparing 3.4 and 2.5, there was no major difference in either efficacy or toxicity, and so that's why the lower dose was chosen. But we can go to even lower doses, and at lower than 2.5, there is less keratopathy. It's not zero, but I think there's a lot of clinical trials out there right now that we're using medications to try to upregulate BCMA on the cell so that we can give less belamaf. There's a combination with a class of drugs called gamma secretase inhibitors, and gamma secretase inhibitors allow more BCMA to be on the cell so that we can use a lower dose of the belamaf, decrease the risk of keratopathy, and maintain the efficacy because we've increased the BCMA in the cells.
And there was a question about experience with continuing therapy, even with grade 2 toxicity.
Yeah, so grade 2 toxicity, the recommendation is to hold, and I follow that recommendation. And this is the type of situation where we bring the patient back in 3 weeks. And again, it's that whole concept of being comfortable holding, because those patients, a large part who have toxicity, will often get better, and we can treat them in 6 weeks instead of 3 weeks. And I think that's probably it. I'd like to thank those in the audience and those online for joining us.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/AHH860. This educational activity is supported by an educational grant from GlaxoSmithKline.